This is new for me, so bear with me here. So, like I said, our learning objectives today are discussing the different types or various of contraceptive methods. So here I'd like you to have a knowledge of the different types available. So when you are counseling a patient, you can inform them that these are the choices that they have. Determine the important points in history taking of contraception. You're all familiar with history taking, you're all fourth year students, but there are few areas that you need to ask more about, which have relevance to contraception, that I will be touching upon. Determine the most appropriate method for different cases. And lastly, to discuss the ethical issues in permanent contraception. So these are the learning objectives for today. The way this presentation has been designed is that I have a few cases, and I will walk you through the cases, and while we discuss the cases, I will tell you how each objective, we'll try to get all of the objectives covered. This was ideally supposed to be an interactive chat, but unfortunately on this I will not be able to manage it as such. So what I'll do is I'll try to finish in the next half an hour so that we have about 10 minutes at the end where I can answer questions. Moving to the next slide. So this is a case of a 30-year-old woman who presents to clinic desiring information about contraceptive methods. What further questions in history are required for recommending appropriate contraception? So actually there are two points that need to be covered when we look at this. This is a woman who would like information regarding the different contraceptive methods. And secondly, what information do you want from her to recommend the appropriate contraception? So part of it is going to be the history taking bit, and the other bit is having a prior knowledge of the different contraceptive methods available. As far as the history taking is concerned, okay. Now, these are the areas in history taking which need to be looked in more detail when we are looking for a history for contraception. Age, we take in all histories, okay? But here, age is important because certain contraceptives, namely the combined oral contraceptives, the hormone-containing ones with estrogen, are not so suitable for older women. So especially if they have a history of other risk factors for cardiac disease or for coronary heart disease. So if you have, for example, a 35-year-old woman who would like to go on combined oral contraceptive, the pill, and they have no other risk factors, then you can go ahead and prescribe it to them. But on the other hand, if the woman is 35 or older and, for example, is a smoker and has a history of hypertension, then it is not suitable for her. So that is where age is relevant. Okay, the second point is relationship. So when we are talking about contraception, it is important to know why, if one of the partners comes to you for contraception, to know whether this is going to be a mutual decision, what sort of relationship they are in, the number of partners that they have, because that is going to help you decide, help you guide them towards which contraceptive method is more suitable for them. Menstrual history. Now, menstrual history we take because you want to know before prescribing contraception whether the woman has a chance of being pregnant right now or not. So the last menstrual period, LMP, becomes important. So whenever you are about to prescribe contraception, you do want to find out what the LMP is. Uh, Similarly, you want to find out whether the woman has a history of dysmenorrhea, whether the woman has history of mid-cycle spotting or bleeding. Coming to obstetric history. Obstetric history, the woman's parity is very important when we're talking about contraception. So if a woman already has, for example, 4 children or 5 children and is seeking contraception, then you want to advise more long-acting sort of contraception, where you don't want to have a high failure rate, as opposed to a woman, for example, who does not have any children. There you want to be careful that the kind of contraception that you provide is easily reversible. So the fertility resumes once contraception is discontinued. Recent pregnancy and lactation. So if the last pregnancy, say, was a few months ago, then it is important to have a gap. Again, you want to weigh in the kind of contraceptive that you are going to prescribe and how effective it's going to be and how long the duration it should be. Lactation, whether the woman is breastfeeding or not, because again, the hormonal contraceptives can decrease the amount of milk production. So the combined oral contraceptive is not a means of contraception that you want to provide to lactating women. Previous history of contraception is important, and if they've had any complication, that is important. Then current and past sexually transmitted infections. That is again an important history to know. There are certain methods which when I talk about the methods, I'll touch upon, which actually provide protection against sexually transmitted infections, and certain methods which actually can increase the risk slightly of having the infection. Coming to past medical history, hypertension, migraine with aura, thrombophlebitis, blood and liver disease, history of clotting diseases, history of thromboembolic disease like DVT in the past or pulmonary embolism in the past. These are all sort of contraindications or relative contraindications to the use of combined oral contraceptive pills, the hormonal pills. So this history is very important, because if a woman has a previous history of having had a DVT or a pulmonary embolism, then the combined oral contraceptive pill is actually contraindicated in such women. Coming to family history of blood disease, thromboembolism, breast or cervical CA, these would also be, again, relative contraindication to the use of combined oral contraceptives. As far as these gynecological malignancies are concerned, breast or cervical cancer or the estrogen-dependent cancers, in those women, you do not want to prescribe the combined oral contraceptive. And then lastly, drug history is important. Drug history in terms of, because there are certain medications, for example, when we're talking about some anti-epileptics, some antivirals, some antibiotics like rifampin, rifampicin, um, phenytoin, phenobarb. These actually increase the metabolism of combined oral contraceptive pills, thus making them less efficacious. And so you have to actually increase the dose of the combined oral contraceptive pills, or actually it is better to switch to other methods. So this is one part of the history. The second part, it's important to find out when a woman or a couple come to you seeking contraception, what they like and what they already know about contraception. So you would actually want them to tell you what they know first before you tell them more about the different methods available, and to tell them which methods are more suitable for them. Find out whether they have any preferences. And then you should describe the method that you are suggesting or that they would want to use more in detail in terms of how it works, what the treatment course is like, and what the side effects are like. Okay, coming to the classification of the different contraceptive methods. This is an important slide, as in it will tell you all about the different methodologies available. So there are the barrier contraceptives. When we talk about barrier contraceptives, it says physical, chemical, and combined. So when we're talking about physical barrier contraceptives, we mean the male condoms, female condoms, diaphragms, the chemical contraceptives, as in spermicides, or a combination. Now, the barrier contraceptives are good in terms of they can be used in women where they have complicated medical histories. So, in whom estrogen, for example, or the combined oral contraceptive would be contraindicated, or they have a history of previous infections. The other good thing about barrier contraceptives is that they provide protection against sexually transmitted infections. So this is a plus point of barrier contraceptives. The disadvantage of barrier contraceptives, however, is that they need mutual cooperation between the partners. Also, they need motivation, and the failure rate is often high. Uh, okay, coming to the IUCDs, these are the intrauterine contraceptive devices. They can be first, second, or third generations. So these are like the copper T or the coil that you must have heard about. These are the long-acting reversible contraceptive devices, which can be placed in the uterine cavity and be left for 3 to 5, even for as long as 10 years. With these devices, the only caveat is that if patients have a recent history of a pelvic infection, then they are contraindicated. When I say recent infection, I'm talking about within the last 3 months. So if a woman has a history of a pelvic infection in the last 3 months, or infection right now, then you do not want them to use IUCD. Then there are the hormonal contraceptives. These are the combined oral contraceptive pills, the progesterone only pills, then the depot injections and implants. The combined oral contraceptive pills are the ones are actually very popular in young women. Uh, but you just have to remember that these have to be taken daily, and there are issues with missing doses. The progesterone, and it's the combined oral contraceptive pills which contain estrogen and have to be avoided in women with medical histories that I alluded to before. The progesterone only pill uh, can be used in women who are breastfeeding, and many of the ones that cannot use the combined oral contraceptives can actually use the progesterone only pills. But the progesterone only pills have to be taken at the same time every day, and they may have suffer from withdrawal bleeding. So these are again things that you need to counsel a patient about if you're suggesting these methodologies. The depot injection is good, uh, but the only problem with the depot injection is that the return to fertility may take up to a year. So, nulliparous woman, it is not the best method. Looking, so this is the natural family planning methods. They high failure rate, and here basically advise a couple to teaching in terms of what the fertile period is. Then there is emergency contraception, uh, where oral pills or IUCD. When we talk about emergency contraception, we're talking about when another use the pills were forgotten, or for example, barrier method were being used, and so you want to use another sort of method. Within the next 2 hours or the next 5 days. We will talk more in detail about it when I touch upon another case. And then post-conception, as in if a woman comes to you and they have actually missed a period, and then whether medical termination of pregnancy is and they did not want to have pregnancy and were using contraception, and for some reason it failed. So then this male and female sterilization. So we are talking about tubal ligation, and uh, in these were the slides which I spent more time on. The rest of the slides are basically based on the information that is present in these slides and that I have discussed already. So talking about the second case, this is a 35-year-old woman with a body mass index of 31, and she has a history of migraine with aura. She heard about all. How do you counsel her? So she has shown a preference to the oral contraceptive pill, right? But then if you look at it, her age is 35, and in terms of risk factors, she is obese. She has a history of migraine with aura, right? So, like I had mentioned earlier, that migraine with aura is one of the risk factors for increased thrombotic events, and you want to discourage the use of combined oral contraceptive pills in such women. So you want to give her alternative available, other alternatives. Absolute contraindications to the use of the combined oral oral contraceptive pills are thrombophlebitis or thromboembolic disorders. So somebody, like I said, who's had a history of DVT or pulmonary embolism in the past, you do not want to give these two. Somebody who's had a history of cerebrovascular accidents or coronary artery disease, carcinoma of the breast, or other estrogen-dependent neoplasm, undiagnosed abnormal genital bleeding, known or suspected pregnancy, benign or malignant tumor. So these are some of the absolute contraindications. So in the previous case, the having migraine with aura is also considered one of the contraindications. So in that woman, you would actually tell her that these are the risks and these are the other alternatives present and which would be more suitable in your case. Okay, moving to the next case. This is a 25-year-old woman who presents to the clinic. She's had unprotected sexual intercourse 24 hours before. What contraceptives should the patient be counseled about? So here, like when we were discussing the different methods available, we thinking along the lines of emergency contraception. So emergency contraception, the choice available are the copper IUCD, the intrauterine contraceptive device, which can be inserted up to 120 hours after unprotected sexual intercourse. So it is actually effective till up to 5 days. Or levonorgestrel pill that can be taken for till 3 days. Or the pill that's ulipristal acetate, which can be taken up to 5 days. So a woman who's had unprotected sexual intercourse, these are actually options available to her. So it is important to guide women. And whenever women come to you for contraception, to tell them that these are available to them. Okay. The next case is a 30-year-old lady, para 3. She is not interested in having another child for at least several years. She requires long-acting reversible contraception. Okay. So when we're talking about long-acting reversible contraception, then the IUCDs, the intrauterine contraceptive devices, or the implants are good options, as opposed to, for example, the combined oral contraceptive pill, which needs to be taken daily. So there are 3 types of long-acting reversible contraceptives available for women. So the copper intrauterine device that works for 5 to 10 years, a hormonal intrauterine device that works for 3 to 5 years, or an implant under the skin in your arm, which works for 3 to 5 years. The copper IUD, like I mentioned earlier, is good. Just remember that women who have an allergy to copper, it would not be suitable for. Somebody who's suffering from Wilson disease, it would not be suitable for. And then intrauterine devices should be are not suitable in women who've had a recent pelvic infection or who have a current pelvic infection. Those are women in whom you do not want to prescribe these. Okay, the last case is about a 30-year-old mother of 4 children who presents to the clinic requesting permanent contraception. What ethical issues should you consider in her consultation? So when we are talking about permanent contraception, we're talking about tubal ligation in females and vasectomy in men. Uh, Now, a vasectomy is actually a daycare procedure which is done under local anesthesia and does not have many risks, but it is difficult to reverse. And tubal ligation or tubal occlusion in women is actually carried under general anesthesia. And tubal ligation is where you actually cut the tube or tie the tube, or different techniques are available. And now a tubal occlusion also is also done, where a material is introduced into the tube which occludes the tube. So it takes a while for that occlusion to take place. So when tubal occlusion is done, until the tubes are occluded, you may need some other sort of contraceptive. Um, and with tubal occlusion, it may increase the risk of ectopic pregnancies. That is something that needs to be kept in mind. But the question here is actually, what ethical issues should you consider in a consultation? Now, remember that when somebody comes to you asking for permanent sterilization, you need to talk to them that they should be very clear about their choice. So respect for an individual woman's reproductive autonomy should be the primary concern. So it is her decision, and but you just have to make sure that it's not coercive or forcible sterilization practices are unethical, that she's not being forced into doing it, and that a competent adult patient voluntarily requests sterilization. They must be informed of the risks and benefits of the procedure, including the chance that he or she may actually regret this later on. So you need to sit down with them and talk it out and tell them about the other options available, the long-acting reversible procedures that are available, and tell them that in case she changes her mind later on, the success rate for reversing the procedure is about 60%. So 40% of the time, the procedure cannot be reversed, ectopic pregnancy being one of them. In appropriate cases, sterilization of a male partner should be discussed during pre-sterilization. Patient counseling as an option with fewer risks and greater efficacy than female sterilization. And lastly, doctors should not be forced to perform a sterilization they believe that it is not in the best interest of the patient. So that basically wraps up my presentation. If you have any questions, just raise your hand so I can unmute your mics.